Okay, so good morning. Following on from the last clear aligner lecture we gave, which was the series on open bites, and the take-home message there was expand as your first staging, tuck those sevens in, then intrude to allow auto-rotation of the mandible, because it's more stable to close open bites via molar intrusion than incisor extrusion. But it's okay to detorque incisors, okay? Series 2, which is biomechanics associated with clear aligners for deep bites. We're going to look at this type of individual. And this malocclusion, certainly in Australia, is a lot more common than the high angle open bite. This is what we call low angle or brachycephalic, and what we call a forward growth rotator. So what happens with these individuals, the lower lip is quite muscular, and that overactive mentalis activity causes the upper incisors to detorque. So when you look at these cases, it's the laterals that are actually of normal torque. It's the centrals you need to get out of the way. And the earlier you get the centrals out of the way, the more chance there is for the mandible to grow forward. So I tell all individuals that if you're dealing with mixed dentition cases like this, it's important to kick out the Div 2, make it a Div 1, and allow natural mandibular growth. So for a young individual, I would be doing a aligner that would just kick out the Div 2, and then a bite jumper or a bionator to open, worn at home and at night, and the case kind of fixes itself, right? But today we're going to look at permanent dentition Div 2s. And again, what do we look at in these individuals? We need to look at the lower face height. If the lower face height is overclosed, I'm going to get a lot of my bite opening by extruding my premolars to level the curve of speed. If my lower face height is normal and I don't want to open that face height, then I'm going to get more control on my incisors. So again, it all depends on the communication you have with your lab who's doing the setup. And most labs I speak to, and we work in particular with a company in Germany called TOPS, T-O-P-S. That company doesn't care what aligner brand you're using. They're very big on setups based on biomechanics. But what they tell me is all around the world, they get people who send them cases with no instructions on the biomechanics they expect. They just kind of want miraculously class 1 occlusion, and that's where the problems arise. So again, my lectures are not about what aligner you use, and to be honest with you, in our practice now, because we've invested in 3D printing, we're pretty much doing our own aligners. And why do I like that? Because I issue 10 at a time, and I rescan every 10. And I really control movement, and I don't do refinements, right? What you've got to understand is, in cases like this, there's no way in hell you can predict 18 months of movement and get all the aligners to fit. It just doesn't work like that, right? So, if you look at the literature on aligners and deep bites, you realize that there hasn't been much improvement. Because remember, if you look at parameters of aligners, what is the most difficult movements? Intrusion. And if you need to do more than 1.5 millimeters of intrusion, it's probably not an aligner case, or it's an aligner case with tats. And people don't get that. So what happens is, I get a lot of these transfer cases that are burnt out. They've been 2 years in aligners, and the overbite still hasn't opened. Why? Because the wrong mechanics have been used. Whereas if you're doing it with fixed braces, and this is something I would suggest to you, when I have a really deep bite Div 2, the patient wants aesthetics, but guess what? Their muscular lower lip hides everything. It's the perfect curtain on the lower teeth. So what do? I start these cases with lower fixed braces. I do 2x4, and I do a lower intrusion arch. And my lower intrusion arch controls my incisors. So I get pure intrusion without tipping. Make sense? So once I've opened the bite, then the rest of the case is easy aligner treatment. Does that make sense? But what's my problem? I'm teaching dentists who have no experience in fixed mechanics. All they know is aligners, right? And this pink elephant that shows the case fix itself. Does that make sense to you, right? In the real world, aligners are not good for intrusion because the parameters are so minimal. Some of these cases, you need 4 or 5 millimeters of intrusion, right? Now, we'll talk about looking at the face to determine whether we intrude the upper incisors or the lower incisors. That's another important point you need to communicate to the lab. Now, if I have this individual and they have a gummy smile, happy days. I'm going to torque my incisors and intrude my upper incisors because I want to reduce the gummy smile. Make sense? But the majority of my patients who have this sort of bite, actually their upper lip is covering their upper incisors. So if I go through my auto mode and don't communicate to my lab, and the lab says, okay, well, we're going to do this, guess what happens? By the time we finish, that patient has a smile where there's no incisor, upper incisor showing, but just lip, and it ages the patient's face. Make sense? So communication to the lab, what am I trying to achieve in the smile, and how am I going to achieve the mechanics of intrusion, right? This is the things we're going to explore in this lecture. So although aligners have many advantages compared to braces, you know, hygiene, et cetera, you've got to understand that when I'm dealing with certain cases, I know biomechanically how to get to pole position. And in these cases, I'd implore you to consider some fixed appliances in the lower arch and then finish with aligners, right? But if not, then I'm going to go through the mechanics and the attachments that you'd need. But if you've got a really deep bite and the smile display is good, in other words, you don't want to intrude upper incisors, you are going to need TADs. There's no doubt about it. So if you don't know how to use TADs and you've got one of those cases, it's not an aligner case, all right? So this is the individual. If you look at the Jarrah-Back ratio, which we've covered in earlier lectures, the posterior face height versus the anterior face height, the lower face, the lower third is reduced. You've got a very prominent chin. Why? Because of this labiomental furrow, because of the forward growth. And that's why you've got to be careful if when your div 2 is created into a div 1 and you're going to jump the bite, be careful that the face doesn't look too chinny, right? And in some adults, I will talk from day 1 about a reduction genioplasty. In kids, you remodel and you work with growth. But remember, this overactive mentalis, which is causing the div 2, is also giving you a very prominent nasolabial furrow. I mean, I'm a classic div 2, right? I had the wrong orthodontics. I had extractions and retraction, yeah? So my face height actually reduced. Now, I've had to open up my vertical dimension myself, but even then, you can see that I could do with a lot more lip support. I needed this, not that, okay? So we call these patients hypodivergent, whereas the last lecture I gave on aligners, it was the hyperdivergent. So whether you call it low angle, forward growth rotator, what you're going to see in these individuals is a occlusal plane that's kind of parallel to the mandibular plane. What you're going to see in these individuals is a square gonial angle because these people have massive masseters. And that's why you're kidding yourself if you think you're going to get a lot of stable molar extrusion because the brachyfacial muscles will pull those teeth back into the alveolar bone, particularly in the non-growing individual, right? Okay, so what are the biomechanics? We want to intrude incisors for the older individual, and we allow natural eruption of the molars in the growing individual, okay? So that's number 1. Our goal is to increase that lower face height in most of the cases. The exception, I think, with some of those gummy smiles, and I will discuss that with you. So that mandibular plane angle that's kind of reduced, we want to open it. And the interincisal angle, right, which is what we call increased, so normal interincisal angle of 135. These people, because the lower incisors are pretty much upright or retroclined, the upper incisors pretty much erupt over them. So when you look at the lower arch in these individuals, you have this curve of spee from hell, right? Now, in flattening that curve of spee, you need space, and people don't realize that. And how are you going to get that space? Most people get the space purely by dumping. You never, never, never extract premolars in these individuals, right? Because you will ruin that profile and you will deepen the bite. Last lecture I talked about okay to extract premolars because extracting premolars helps close the open bite, helps that wedge to close down. These individuals need the wedge opening. So you never, ever extract premolars in these individuals. It's sacrilege, right? And then people say, well, I can open the bite by distal driving. Yes, you can. But what is that going to look like in the face? Remember, these individuals need more lip support. Their nasolabial angle is not acute like the high angles. Their nasolabial angle is open. So what they need is the Div 2, Div 1, bite jumper, and mandibular translation. You can still get a good occlusal result by distal driving the molar because that opens the bite, yes, but the face is going this way. Do you understand? There's lots of planning here. And that's why I say to you, do a proper orthodontic course before you hop into aligners. Most orthodontists like myself, we have the background in biomechanics, and then we understand how to treatment plan. People who just say, right, future of orthodontics is just aligners and let's just go with it, they really struggle in these cases. All right, so let's look at the individual. There's the intraincisal angle. It should be 135, let's say. But in this situation, you can see the intraincisal angle is increased. And it's increased mainly because loss of torque of the upper anteriors and the deepening of the bite. So let's look at this individual. If someone showed me just that photo and asked me to plan the mechanics, I would say, I can't. Why? Because I'm missing the smile photograph. Is this patient showing a lot of gum? In which case I'll plan to intrude and torque my uppers. Is this patient not showing enough incisor? In which case I'm going to really extrude the uppers. And how can I extrude the uppers? By really intruding the lowers. And this is what we need to discuss. What else do I need to look at? What is the AP cephalometrics looking like? Is this going to be a case of creating an overjet and bringing the mandible forward? Is this going to be a case of opening the bite and distal driving, you know, like a carrier motion case? Let's look at this individual. She's an adult and she has a loss of posterior vertical dimension, right? So if you look at her OPG, you can see a 6 was removed a while ago. And so that 7 has dumped. Now, it's next to impossible with aligners only to upright that tooth and intrude it. But that's what you need to do, right? So if you get the opportunity, if you go to eodo.teachable.com, there's a fantastic 1-hour lecture by my friend and colleague, Dr. Ivan Malagon, talking about biomechanics with clear aligners in these individuals. And he goes through a clean check on a very similar case where he uses a TAD to upright and intrude the molar. And then he controls the curvus B by not extruding premolars, but focusing on lower incisor intrusion. It's a very good lecture to specifically look at the planning cases. And remember, our teaching institute, through EODO, we follow the COIPE protocol. COIPE is the Clear Aligner International Program put together by Ivan and Diego. And what I like about it, it's all about looking at the face and the smile. It's not about just getting straight teeth. So to me, I'm a Damon sort of user, and I like those mechanics, that nice broad upper arch as the template. Ivan and Diego will come from that Damon background. So they've just taken Damon mechanics and converted them to clear aligner. It's very, very good. Right? So in this individual, what are our goals? Well, in staging, what do we have to tell our lab? Start with the upper arch. The upper arch is the template, is the key. This upper arch will need correction of the Div 2, expansion, right? Rolling in of the 7. Got that? Second thing is, where does the mandible go? Is there a big overjet? And we might need to use some of the newer aligners. I'm really impressed with a new, well, they're not a new company, they're a new company in the world market, but they've been in China for 20 years. It's called Angel Align. And Angel Align have a series called A6. Write that down just to look up. A6, Angel Align. If you need a case that needs mandibular translation, that company's got it much better than the others because they have come up with aligners that have really rigid twin block attachments to them. I've tried the Invisalign one and it just falls apart, right? Great idea, great concept, but these guys have pulled it off. So when you need a patient who needs mandibular translation, seriously look at Angel. I don't promote one product over another. I haven't in my lab home setups been able to replicate what they do, but the A6 Angel is really good on these class 2s, right? I was speaking to my friend, Dr. Vass, who's a very talented orthodontist in Australia. In fact, did all the clinical trials for the world in Spark. I'm really proud to say Spark aligners developed here in Australia before they went around the world. That's very unusual. And Vass did all that research. And he will tell you that when it comes to the class 2 cases, even though he's a big Spark user, he goes Angel on those because he's really happy with these twin block attachments, right? So I need to kind of plan this case. I need to communicate to my technician, what am I going to do? And if I'm going to do Copy protocol upper, yeah, intrusion of lower incisors to get them out of the way, then translation, I've got to communicate that staging. So I don't need the twin block on the first set of aligners. Make sense? How can I? The Div 2 is blocking my mandibular translation. It's like having, the upper jaw is the garage, the lower jaw is the car. I can't drive that car forward because the roller door is shut. There's your Div 2 incisors. Do you understand? But if you don't communicate to the lab, how the hell do they know what you want or what you're going to do? Most labs will create space via IPS and distalize it. You understand? Just by default. But you've got to control the staging. And the more you get into the aligners, the more you'll understand that staging is best done in increments, right? Stage 1, develop the upper arch. Stage 2, intrude lower incisors. Stage 3, jump the bite. That's the protocol we use in these cases. And in this case, what makes it even more difficult is that you've got to deal with molars that have tilted and lost posterior vertical dimension. So again, it's very hard to get that intrusion with aligners. It's impossible because I'm talking about uprighting, easy with aligners. Perfect, because the aligner is your anchor source. Once you upright, intruding, almost impossible unless you put TADs in there. So in this case, we'd be using TADs in the buccal shelf, a la Chris Chang, to do the intrusion. In this case, in our staging, I'll be using TADs mid-treatment in the lower incisors to intrude them. Do you understand that? In stage 3, towards the end of treatment, I'll be using the A6 bite jumper. See the planning? Right? And we'll look at this as we go on. But this is what you've got to understand in these patients. They almost have 2 lower occlusal planes. Their lower 2 to 2 has over-erupted. Why? Because that forward growth has been impeded by the Div 2 incisors. So what you've got to plan here is leveling that curve of speed, right? And you can see there's no way in hell, and I'll say this again, right? There's no way in hell aligners on their own, no matter what brand, no matter what attachments, will intrude those incisors that much. Think about it. You've got about a 1.5 to 2 millimeter parameter of aligners only. That case is a 4 millimeter lower incisor case. Unless you pray that it's a growing individual, you pray that the lower facite needs opening, then you can get some help by extrusion. Make sense? But if it's not that case and you have to do a lot of lower incisor intrusion, you'll need TADs. Or better still, start the lower in fixed before you scan ready for aligners, right? What people got to understand is in complex cases, it's a hybrid case. And the benefit with the new technologies that we have, Insignia was a market leader in that regard. Now you have things like Light Force. They're all computer-generated movements, so you can switch from fixed to aligners all within the same software. Ormco now have Approver software which allows you to integrate between the two modules. But you've got to understand that and go with that. So we're going to explore what type of cases, what types of movements, but what's our goal in these cases? They have this classic labiomental fold, right? They have this witchy poo chin. They have a curve of spee that's greatly increased. So all of these mechanics means that what we have to do is we need to plan to support the face. Now look at this girl. She's a classic, that's her ceph, that's her face. If you retract and open her nasolabial angle, it's going to worsen her profile, and she's young and still growing, and she'll look worse as she gets older. Do you understand? The second thing, how much gum does she show on smiling? In her case, she doesn't show any gum. So the last thing you want to do is upper incisor intrusion. But if you don't communicate that to the lab, it's very easy for them to open the bite via upper incisor intrusion using attachments. Okay? So that's another communication tool. So we're dealing with a crown root angulation on our teeth, which is increased. We're dealing with over-eruption at the lower incisors, curve of spee problems. We have a high tongue position. Remember in the last course, we talked about those high angle patients that have a low tongue position, and we want to really develop that arch and start our myofunctional therapy to get the tongue up there. Here, the tongue goes laterally. These patients, have a look. They have a square jaw, square arch form. The sides of the tongues have scalloping, do you understand? So the tongue is sitting between the interocclusal plane. That's why the teeth can't erupt. Do you understand that? The tongue is intruded and give you that curve of spee because the tongue has no room. Our job is to get that tongue and get it up on that upper arch. And that helps us with our movement. So high tongue posture, a lot of these people have loss of posterior vertical dimension and even worsened if they had teeth out. So treatment objectives in this sort of individual, yes, we want to resolve the crowding because that's why the patient comes in. No patient comes in and says, Dr. Mahony, I have a deep overbite and I think that needs to be opened. And if they say that, that's red flags. They normally come in and say, I don't like my crooked front teeth, particularly my second teeth. And then I have to break the news to them, the second teeth are the ones that are actually in the right position. You know? Okay, so our interincisal angle, we need to reduce, right? It's increased. We need to, if you look at this paper by Houston in '89, he said the stability of these cases is to bring the centroid of the upper incisor lingual to the lower incisor tip. That's so true, because what you're doing is that, okay, and then this. And that's what gives you the stability, and it also supports a facial profile. What I don't know is where am I starting, and that's why I need a cephometrics. If these lower incisors are retroclined, many of them are, because of the deep bite, then yeah, I can get some space by proclination. But if my lower incisors are already like 95 to mandibular plane, I've got to be really careful not to dump, because everyone thinks you're intruding, but pure intrusion is next to impossible. What you're really doing is reducing the overbite by that. Do you understand? And if you do too much of that, watch out for periodontal problems as the patient ages. Right? So look at the lower incisor to mandibular plane angle as part of your treatment process. Look at the amount of curve of spee you need to reduce. Look at the amount of incisal display to determine what you're going to intrude. These are the things that we're talking about. But I really implore, even though the first part of this lecture is on adults, later in this 2-day program we'll be discussing the real mechanics, which is just kicking out a diff too early in mixed dentition, giving the kid a bionator, and just sending them on their merry way until 7s are up. The case fixes itself, right? Because in a growing individual, I can use an upper sagittal appliance or sagittal aligner. I can then use a functional appliances, which is encouraging vertical development of my posterior teeth, and that's because the patient's growing. And once I've done all that, because of my forward growth, remember, last course we talked about Bjork and Skeeler, and these individuals are not the backward growth rotators, they're the forward growth rotators. So because they're programmed to grow forward, much of their class 2, much of their lower face height fixes itself with that growth. But if you have an adult who doesn't have that growth remaining, you can do some repositioning of the mandible because you're untrapping it, but you really don't know how much you're going to get. And that's when you have to decide mid-course, can I use bite turbos on my aligners, bite ramps as they're called, or is this going to be an A6 case like I've discussed with you earlier? So question number 1 in our diagnosis of these cases, that deep bite that we see anteriorly, complete to the palate, is it caused by supereruption of my upper incisors? Maybe in a gummy smile. Is it caused by supereruption of my lower incisors? Or is it caused by infraocclusion of posterior teeth? And that's part of the diagnosis, because then you know to tell your technician what your biomechanics are going to be in this case. Now, how do I evaluate whether I have an infraeruption or supereruption present? I've got to use my linear measurement cephalometrically, but from the alveolar process, right? And that's why you can't do orthodontics unless you understand some cephs. And if I have a classic Div 2, right, low angle patient that's biskeletal retrusive, that's a whole different ball game to just a class 1 that has a dental Div 2. See the difference? And as I said to you, I've never had a patient who comes in and says that their sole reason for seeking treatment is the deep bite. They come in because of aesthetic concerns, or they're referred in because of loss of posterior vertical dimension, overloading of the joint, wear of incisors. You know, that's fair enough from the referral to me from the dentist. But whatever the primary cause of the deep bite, the cardinal guide or the cardinal decision-making process for me is going to be the lip and smile line. It's really important that you get that patient out of the chair. When you take their photo extraorally, make sure their eyes are changed, meaning bicularis oculi is working, because what you want is a full smile. And that full smile will then tell you how much upper incisor they're really showing. And that's an important criteria here, because you could launch into standard mechanics that would be acceptable for the occlusion, but non-acceptable for the smile. And David Sava, who really is a breath of fresh air to our profession, when he rewrote Prophet's textbook, he changed a lot of the diagnostics into facial driven. And he says a perfect occlusion at the expense of facial aesthetics is deemed a failure in orthodontics. That's big terms. When I graduated from orthodontic school over 30 years ago, we just put plaster on the table to pass the exam. No one looked at smiles. So you could end up with angles class 1 back here in the face and you got top marks. But now we realize, geez, that's just not on, right? Let me give you an example. Here's a patient who is classically low angle, brachycephalic, deep bite, Div 2, increased curve of speed, prominent labiomental furrow, all the things we've discussed, right? Now, what's missing here, right? And this is why if you're working with a lab, which all of you are, one of the things you need to ask yourself, is that lab accepting this and an intraoral scan for diagnosis? And if they are, you've got a question, do I want to work with that lab? Adriana, what's happened here? No, it's all right, just it went blank and then... if that lab says to you, and if you write down Matthias Pepper, just write that word down, Matthias from the Bible, Pepper, easy to remember, right? Salt and pepper. Google his name, Google German aligner laboratory, Google TP solutions, any of those search engines. Look at this guy. He was the lead sort of technician for align technology for 10, 15 years, right? He's done more aligner setups than anyone else in the known world, right? And what he asked for as part of his upload is a smile evaluation. Really important, right? I'll tell you why. So look at this case. If you go to auto mode, you're going to say deep bite, let's intrude upper incisors, okay? So years ago, if I did this with fixed, I would put my upper and lower brackets or attachments very incisively because I wanted this. Understand? I would do with wires my reverse curve of sphere wires because I wanted to level the occlusal plane. So the biomechanics are very similar. Intrude, right? Level curve of sphere. Got it? But if I do that and I put my brackets here without looking at the face, what's going to happen? Brackets or attachments. I'm going to go from here to here, and it's going to look impressive on study models. Do you understand? Because the bite's open. We knew that was going to happen. When I then look at the kid's face at the end of treatment, right? Is that a successful orthodontic outcome? And that kid's still growing. His upper lip is going to get longer. So really, who cares what orthodontics he had? That's the one that you guys would love to do anterior implants, and because the lip will hide those shitty, emergence profiles, and he's the one that you don't want to talk to him about changing his VMK crowns, because at the end of the day, no one sees the mental margin unless he walks around like this. Poor guy. Do you understand? Now, do you understand how it's really important when you're planning your aligner treatment, you look at the face first? And now, let's look at him if we were going to do his case again. We're missing the smile, okay? Knowing that smile, knowing that his lip covered most of his upper incisors, where would we do our mechanics? All lower incisor intrusion, 100% lower incisor intrusion. To the degree I want to do the original setup with an open bite. Why? Because my finishing will be my upper incisors extruding to show more smile. Does that make sense to you? Big, big difference in planning and setting up that case. And we will show you along the way what attachments to use to get that extrusion. So there he was pre-treatment. That was the missing photo in the diagnosis. Looking at that photo, you say, whoa, 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 please do not intrude the upper incisors. And yet, without that photo, the lab has gone and done an automatic setup to give you a good orthodontic result, but a very poor facial result. I really take my hat off to this guy, Tom Pitts from Reno. He was one of the first orthodontists to start really publishing about Sava's smile arc. Sava had really good articles on what is a beautiful smile, buccal corridors eliminated, showing all upper incisor, maybe 2 mils of gum, but no lower incisor, good talk. We know what we're looking for. But he's the guy who said, well, biomechanically, this is how we achieve it. So if you're doing fixed, you can read his articles, and he talks about using high torque brackets and also placing them a little bit more gingival for a case like that. But you can translate that to your aligners by talking about starting with a lot of lower incisor intrusion, having high torque, and I'll show you how you achieve high torque with aligners, and most importantly, then looking at the finishing. And that's why I do my aligners in stages of 10. Okay, so a couple of gurus that I go to, Matthias Pepper, TP Solutions, Ivan Diego, their master COIPI program. Why? Because it's in tune with our philosophy. And remember, I made this point before, a really good Formula One racing driver can change 3 teams, 3 different cars, and still get pole position because he's got skill. These two, they started with Invisalign, with Spark, they do a lot of, what do you call it? Just use that company, Angel cases. But they still get good results because it's not the aligner that influences what they do. It's their understanding of the mechanics, right? So three basic concepts if you're following that protocol. And that is upper arch development. I like these guys because they hardly extract. Neither do I. I like these guys because it's all about looking at the upper arch. Then you look at lower incisor position. And in this last case, it was all about lower incisors being intruded and whether they're going to be proclined or not. Then you have your sequence of movement. So let's explore that with the aligner setups. Let's look at this case. Good amount of upper incisor display, correct? So you don't want to intrude or extrude the uppers. However, you definitely want to talk. How are you going to get room for that? If you send it to a normal setup, they're going to IPS, IPS, IPS. Does she need IPS? If you don't know how to do development with your liners, yes. But if you follow the COPE protocol, this would be staged into arch development upper, talk of upper incisors, intrude lowers, bite jump. And you write that in your notes to the technician. I want you to stage this way. And then you look at that setup and see if they're staging it correctly. Everyone understand that? There's the skill level. The other thing you've got to be careful of is how are they going to correct the class 2 molars? By default, a lot of these labs press a button which will distalize the upper molar. Okay? Now look at her face. Look at her nasolabial angle. She needs this support, not that support. Now if you look at her end result, beautiful occlusion. Good interincisal angle, tick. Molars, buccal segment class 1, tick. But look at the face. Look at where she started. Look where she ends up. Those mechanics distal drove. And aligners are good for that. Why? Because all your anterior teeth are your anchorage in an aligner. When I talk about movements that work, molar uprighting, distal driving, all very good movements for aligners. Things that don't work well with aligners is intrusion, okay? But in this case, acceptable end result, and that's what you'll see on your computer, but not good in the face. So again, facial-driven mechanics are to tell your technician, I want this case to be upper arch developed, tuck the 7s in. Full torque of my upper anteriors, see where we are. No computer can predict how much that mandible is going to spontaneously come forward, can it? But if it comes forward a lot, then my finishing will be bite ramps. If it doesn't come forward a lot, my finishing will be my A6 twin block aligners. Everyone get it? And I'll end up with this and a good face. So staging of movements in clear aligners is much more important than attachment selection. You want to create space for tooth movement, and the only way you're going to do that, I feel, is arch development. If you're going to do that with IPS, it's very unpredictable because you have to round trip. You can't IPS like this. You can't get to the contact point. So you flare, create space, and then IPS. That's round tripping. I like the diamond-shaped arch. That's why I work a lot with COPE protocol. I work a lot with Matthias because they understand that concept. They even have a default, which is not called angles class 1, not called, Andrew's setup, which is a default setup, but really a broad arch or diamond shape. Use the biggest attachment that fits, so that's going to get you the movement. And we always have those 3 passive aligners at the end of treatment. But the big thing here is we want fully aligned teeth before even deciding on IPR. No computer program can predict IPR until you've done your arch development. That's the difference. So write that in your notes. If you're getting you're getting setups back from any lab that's talking about IPR from the first couple of aligners, walk away, walk away. Arch develop first, see if there's need for IPR. And you will be more accurate if you reduce IPR. Who would agree? You get what I'm trying? People always say, these aligners are not tracking. And I look at the setup, of course it's not tracking because it said 0.3, which how do you measure that? IPR aligner 2. How did you do that? You did 0.5 and you did it at the wrong contact point. And you reckon the aligners are going to track. Do you see what I'm trying to say? If you say no IPR, write it down, no IPR until I do my first protocol and I want expansion. When I get expansion, I'm going to get this in brackets. Oh no. And then I have to do torque in my other wires. in aligners, you can really control some of that tipping. That's what's good about them. You can get expansion with aligners if you stage the first stage correctly. I've probably, routinely can get 5 mils. Probably more than that, then I'm going to use an expander before I do my aligners. So that's another parameter that I look at. That's him there. Matthias, really good speaker. If you look at some of our lectures, again, on eodo.teachable.com, I've had him as an invited speaker on our program, going through what's called staging protocols for Copy, Damon type mechanics. And I like his company motto. We love well-structured aligner education. I like that. Because right now, most people, aligner education is an online course where they can somehow virtually take your pulse and say, right, you are now ready to start providing aligners to all your patients. This is more structured. So the software algorithms that he's come up with for deep bites are like this, right? Now, you'll get a copy of all these slides. For those who are interested, just send an email to my team at EODO or my email info@derekmahony.com, and we'll share this stuff with you. And this is after not 5 cases, but in his lab, probably 20,000 deep bite setups, and then see what actually happened and learn from that and change your algorithms. See the difference? So, arch development, Copy protocol, tuck the 7s in. Proclination, until your inclination is perfect, you got rid of the div 2. And with aligners, 5 degree of overcorrection. Then your intrusion, is it upper for gummy smile? Is it lower for that curve of speed that the kid doesn't show any incisor like the one I showed you? That's your decision. You've got to tell them that. But they will give you the attachments where they need to be to achieve that goal. Lastly, no retraction on most of these cases, but bite jumping. Did everyone see that? Really important protocol. Now, as far as your Anchorage attachments, you want to have them as close to the anteriors as possible because that's where all the work is being done. And this is where good quality labs can help you with setups. Because where anyone struggles without experience is the original setup. Most people I know, and I speak to all the big labs in the world, they say 80% of doctors don't even look at their setup and just press default because they're busy and they just want to get the aligners in. And they book the patient in normally 4 weeks after the consult because that's how long it takes to get aligners. What you should be doing is not even make an appointment for fit aligners until you've allocated enough time to really look at the setup, look at the mechanics, blah, blah, blah. It's an easy sell to patient. I mean, you sit the patient in front of you, say, this is where you are, this is where you want to end up, and it's like magic on the computer. So when do we start, right? But you've got to go back and look at what you're trying to achieve along those parameters. Now, if you finish this first stage, development, second stage, torque, intrusion, then you look at where the mandible ended up. No computer can predict this. It's a biological change. If the mandible has tracked forward naturally, then I can finish this case with some bite ramps, all right? If there's a massive overjet, I can't put bite ramps. And if I do, I could actually be causing the mandible to hit and be pushed back, causing TMD problems. So that's when I'm going to go to my bite jumpers, right? This comes from an excellent article, which I'll reference, Neil Kravitz, in setting up aligner for good biomechanics. And what he says is when you have those incisor bite ramps, you need that hypodivergent patient where you're going to do some posterior extrusion and some mandibular en masse incisor intrusion. They're all your thing. What you don't want is to do it in a vertical grower, right? Because that's going to cause more molar extrusion. You don't want to do it in the maxillary incisor intrusion patients. But in most of the cases we're looking at, you want lower incisor intrusion. You want that curve of speed level, right? So I'll reference that article in a minute. There's what I'm using now. And I can't predict this until I've done stage 1 and 2. If I've done stage 1, beautiful arch development, tuck the 7s in, stage 2, incisor torque and incisor intrusion, then I see what I get, right? If my mandible's tracked, I've got a minimal overjet, bite ramps. If not, what I call bite jumping or jumping the bite. This is the A6. And I can't do those, unfortunately, in my own lab, right? But they work. And to be honest with you, nowadays, I'm using this on snorers who come in because of snoring sleep apnea. And rather than just give them a mandibular repositioning appliance, I say, would you like straight teeth with that? That makes sense? And the answer is, yeah, right? So how good is that? That we can align their teeth. And really, a lot of these snorers are Div 2s, and a lot of them have had unfortunate orthodontics as teenagers. They've had 4 teeth out in this. No wonder they snore, because their tongue has no space. It's sitting on the back of their throat, right? For large overjets, I'm using these sorts of things. Then Matthias uses what's called frog staging, right? And the frog staging really looks at, do I have lower 3 to 3 that have over-erupted, or just lower 2 to 2? And we look at doing sequential leveling based on the canine. And that also is years of algorithms and seeing what works. So write down in your knowledge base, frog staging, write down COPI protocol, and get to know this sort of stuff. Because then your finishing becomes really easy. You know, you've got 3D tools now where you rescan a lot. So as I said, my protocol nowadays is 10 aligners maximum and rescan. I tell the patients that. It's not like, I don't know, everyone thinks aligners are a bit like Uber, where in theory, you hop in the car, you punch in your destination, you have a good estimation of where you're going to go, right? And you get there on that ETA. Real aligner is like hopping in an Uber where there's roadworks everywhere. Does that make sense? And you've got to keep changing your destination as you're traveling. So that's why you don't know until you get to stage 3 of that protocol where your contacts are and how you can further improve those. And at this stage, of course, you've got to take away the bite ramps to allow the finishing to occur. And at this stage, sure, if you need to do some IPS, and I normally do it in teeth that were triangular, because now that they're aligned, there's probably going to be dark triangles, the older the individual, right? Now, this is the article. Please read this. If there's one thing you do after this lecture, I want you to read this article cover to cover. It's available online. If you can't get access to it, send me an email. I'm happy to share it with you. Neil Kravitz, very talented orthodontist, big in the aligner movement, right? In this paper, which is published in Seminars in Orthodontics in 2020, he talks about correction of deep bite malocclusions, and he says it's a challenge for orthodontists, right? But with case setup, attachment design, bite ramp utilization, you can get good results. Really good article. And from that article, he has what we're talking about, a protocol to level that curve of speed as stage 2 staging. Now, who's awake here? Stage 1 would be what? Arch development, definitely. Stage 2 is normally incisor control, which, yeah. Now, incisor control is torque and intrusion. Torque is easy with aligners. Intrusion is harder. Everyone get it? Lots of horizontal occlusal beveled attachments on the premolars, particularly, if you're getting those vertical changes. If your goal is to level your curve of speed, how are you going to do that? Is it going to be via extrusion of premolars? And that's going to open face height, great. But if you don't want face height open, you've got to control that with again, the right attachments. And from his article in figure 1, he's showing you what we used to do with our reverse Curvus B wires. The flatter the mandibular plane, the more over-engineering of that virtual case-up you need, right? And that's particularly true in cases where there's lots of IPR. Now, in this diagram, obviously, he's removed the attachments for clarity, but can you see the Curvus B? And there's no way in hell that amount of intrusion is going to occur with aligners. So look at your setup. If the lab is showing you that setup and you're measuring more than 1.5 mils and they're saying you can do it with aligners only, you're kidding yourself. That's telling me, before I start, to warn the patient that we're going to need TADs. Okay? But I might look at that setup from the lab and realize the patient had a gummy smile and say, whoa, 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 I don't want that, because if you give me that, I'm not addressing one of the patient's concern, which is the amount of gums they're showing on smile. So he's come up with, he's a big Invisalign user, so obviously he's giving you a kind of template for ClinCheck, for a deep bite. And he says, exaggerate all those measurements in the non-growing individual, 100%, because we're not having that forward growth. We can't rely on it. We don't get stability of molar extrusion in these patients. And then most importantly, selection of bite ramps comes earlier in the prescription. All this stuff, if you say, oh my God, no one taught me this on my aligner course. Well, maybe go back and do a proper aligner course. Not just mine, there's lots of aligner courses, Kopi, Matthias, but do a proper course where they're going through this sort of stuff, rather than most courses, how do you submit the case and how do you get your provider number for the software? That's all BS. What else? You've got your curve of Wilson rather than just your curve of speed. And on these patients, remember, there's a lot of this going on and a lot of the lower incisor intrusion. So in this occlusal view, it's showing you the resultant intrusion of those mandibular incisors. And then you look to say, well, how much proclination are they planning here? And if my lower incisors are retroclined, that's acceptable. If my lower incisors are right on the money or worse still proclined, like remember, a Div 2 is a different animal to a Div 1, even though both have deep bites. A Div 1, the lower incisors are probably already proclined a little bit to compensate, right? We need to look at that. Now, this is Invisalign's dome-shaped G5 attachments for those who are used to those, and the G7 on the first molars. So they may not be possible in a younger individual, maybe because of shorter clinical crowns, but in the older individual, definitely. And, your canine is, again, that frogging protocol. Where are they going to end up in relation to that as your anchor source? So great article, particularly if you're an Invisalign user. And remember, I don't care if you're an Invisalign user, Spark user, make your own aligner. I don't really care. I just care about what movements will occur with any aligner. What you've got to understand, it's not the plastic that's important. Every company says, I use Zendura. They all work. They all move teeth, right? It's the attachment. It's the biomechanics that makes the difference. You cannot align teeth without attachments. I think all those online companies have learnt that the hard way. Correct? But what attachments you use and where you place them is very much determined by your initial setup. So say, for instance, in situations where you have a lingually placed lower incisor and you need buccal root torque, meaning if that's your lower incisor and it's standing in a crowded case, most of the alignment's going to be like that, tipping, very unstable. And when you look occlusally at your finishing, you'll see the gingival margin on the lingual of that too doesn't match all the others. So that will need buccal root torque, or known as lingual crown torque, whatever. Yeah. So you need to ask for that. And then during your incisor intrusion, you need to really control that as part of the process. The term round tripping, I use that a lot. All it means is that you're tipping the teeth buccally to give you access for IPR, if that's your objective, and reducing collision. Collision means teeth are not going to move, no matter what movement you're going to do. But to me, I minimize IPR because I do a lot of arch development to begin with. So that lower curve-free protocol will be applied sometimes at the same time as the expansion protocol as you get experience in the case. But if you're new, just make it go a little bit longer, more predictable. Do your full arch development, create your space before you start doing the second stage, which is the incisor torque and incisor vertical control. Are your lateral segments being uprighted? And at what stage is that happening? Are your sevens being compressed? Important part of that COPE protocol. Now, when you apply lingual root torque on the sevens while you compress them, that gives you a hell of a lot more anchorage. So that helps you torque your incisors. So you might want to factor that in that early stage. And the most common reason for that steep curve of speed is your narrow upper arch, because your incisors have nowhere to go. Remember the analogy of the upper arch is the garage, lower jaw is the car, and you can't drive that car forward until you fix that narrow upper arch stage. So expand and align arches first, then go back to your technician and say, how can we coordinate these arches? With midlines, which you may have problems with, don't correct those by asymmetrical IPR, because you're going to get a really shit finish. Does that make sense? If the midline's out and the teeth are the right size and shape, don't do it by IPR, do it by distal driving mechanics, or the space you created by your arch development, start moving the teeth in that lateral movement. So order of planes to be corrected: number 1, transverse plane; number 2, vertical plane; number 3, sagittal plane. Please remember that. They're like your, 3 commandments in aligner therapy, regardless of what case. And we went through those 3 in the last series on open bites. Now we're doing the same for deep bites. And remember, at the end of the day, if you've got an open bite class 2, you still have a narrow arch, the tongue's not there. But your vertical is molar intrusion. Here, your vertical is incisor intrusion and torque. See the difference? And when you finish in a class 2 open bite or class 2 deep bite, class 2 open bite, it's auto rotation. No bite ramps there. Deep bite, it is molar extrusion, bite jumping, translation. And when you translate, you have a lateral open bite to deal with, correct? Because the curve of speed, so if you have a div 2, you make it div 1, you bring the mandible forward, look on the buccal segments, you'll see the lateral open bite because the curve of speed now has come forward. And how are you going to control that? Are you going to do intrusion or premolar extrusion or combination? Look at the lower facite in that regard. So our upper incisor protocols, Procline first, because you can't intrude if your roots are not in cancellous bone. It's dangerous to do pure intrusion on under-torqued incisors because the roots are hitting the cortical plate. Okay? Now, let's turn that off. That's my timer, I think. We're running good on time. Now remember, guys, with questions, because I'm doing this for Zoom, for YouTube, for whatever, we'll do questions at the end, and we'll take questions for those who are on the Zoom platform as well. You just have to type those into the Q&A. Okay, so I've talked a lot about more than 1.5 mils of incisor intrusion, you need TADs. Let's talk about TADs. The TADs that I'm using in the buccal shelf, like for that lady who had the molar tipped and I needed to upright it intrude, they're the long 2 mils 12 buccal shelf TADs. For incisors, I can't have a big screw or a long screw because I'm talking about very thin interradicular spaces, right? So what I like using is the 8.1.5. Again, don't care what brand you use. Personally, I love Chris Chang's OBS screws. They're really well designed. They're stainless steel. They don't fracture. They do the job. So last course, I was talking a lot about IZC for my molar intrusion, remember? And with aligners, I can run an elastic from here over the posterior part of the aligner to the palate, and I can get really good intrusion. That was last course. This course, we're talking about using this in a deep bite gummy smile, or those in the lower for a deep bite, big curve of speed, not showing enough incisors, for anything more than 1.5 mils, okay? So let's assume this is a gummy smile, deep bite, and I want to get that. That's way more than 1.5 mils. So what I'm going to do is I'm going to place those TADs, 8 times 1.5, and use some free resources here. Google Chris Chang, incisor intrusion with TADs. He has like 6 or 7 beautiful YouTube videos for free. Chris is great on sharing education without charging the world. And he'll show you these mechanics, which we'll discuss as we go along to this 2-day program. When you want to intrude using aligners, it's not just having the TADs there, you've got to have the attachments to allow that entire segment to intrude. Just like in my high angle cases, I had IZCs and palatal TADs, remember, right? Here, I'm using that as anchorage, but my elastic needs to come around and intrude bodily. Otherwise, I'm just going to get a flaring and tipping. So these mechanics, upper or lower, are what you'll set up, and you've got to say to the technician in your stage 2 protocol, hey, now I want to get 4 mils of upper incisor intrusion, or 3 mils of lower incisor intrusion, or combination of the two. And tell the technician you're going to be using TADs for that. So how do you place these TADs? Where do you place them? Ideally, you place them between central and lateral. Sometimes I just don't have the room. That's why I always look at CBCTs, right? If I don't have the room there, I put them between the canine and the lateral, and I always have room there because if you look at a canine, it always has tip, so the root flares away from the lateral, but biomechanically it's not as efficient. These do have a high failure rate, more so than the buccal shelf and the IZC. Why? Because there's not enough cortical bone. When you go this way, you're getting mainly cancellous bone, which is not good for mechanical, but there's not much you can do. And plan B, if these keep falling out, is go back to standard mechanics. And I say to some patients, listen, you want aligners, I can do it with these, but if these fall out, and I don't know because your bone may not be as dense as I'd like it to be, then we need to go to braces. And I warn that in my consent. Right? And those of you from last course didn't get my aligner consent form, please send me an email, happy to send it to you, because it tells patients that aligners achieve so much. In your particular case, it may not be what we need, and as a result, I reserve the right as the treating clinician to be able to swap to brackets at any time. If you're not wearing your aligners, we dump out and there's a whole new fee for a setup, blah, blah, blah. Certain things that the generic forms you get from the aligner companies actually don't mention or cover. So, 2 ways to get that intrusion. One is the Chris Chang method, going around the aligner. The other is attachments and cut the aligner. And I'll show you both of those. So we know when we need to intrude. This is why in our aligner program, we have theory, but we also have practical. And that's where the Zoomers find it hard. because it's really hard to be able to do that remotely through a computer. We need to sit you down, show you a case being done, make you do it on a typewriter. Some people prefer this method of intrusion where you've got your attachments on the teeth and you just use aesthetic buttons. What are these? To be honest with you, I use a O-ring. I etch, use a primer. I put some composite, tooth colored, and then I put the donut O-ring, and then I light cure. And when I peel away the donut, I've got a perfect cheap button. Or you can buy these and they're pretty expensive. But this is one method of non-compliance because you don't need the elastics, you use the power chain. But if you're using the elastics, you need good compliance. And sometimes if they're not doing the elastics, you need a plan B. And that's where you have to do a reset up because that's a different type of biomechanical movement. So again, using those 1.5 times 8 mil, get your Explorer probe, do an indent. So you have like a visual guide of where you're going to place those. Adriana, pretty soon we're going to open questions, so you let me know if there's anything from the Zoom crowd. Now, if you're putting power chain, like I just showed you, I'll show you the technique. These slides are using fixed, but you can do it, as I said, with the buttons on the teeth. So probe, make sure you have the interradicular space. Then you're coming in at that angle. You're straightening up. You're checking your torque. Same on the other side. This is an easy case. You can see the interradicular space is pretty good. You want to be definitely below the mucogingival junction, or that thing's just going to wrap around. And Chris Chang has beautiful YouTube videos on this. So place your TAD. Then you can use your power chain or your elastic. If you use your elastic, you've got to cut out on the palatal and put either, some people like putting, if you have those Hugh Freedy pliers, you can put a notch in the aligner, or you can cut the aligner with your punch and put a button. Now, on the lingual, I use the metal buttons. They're stronger, and the patients don't see them. Okay? So they're the two sort of processes. So to summarize the movements to correct a deep bite, you can extrude posterior teeth. Younger the individual, more stable that is. You can upright posterior teeth. Aligners are very good for that. You can distal drive posterior teeth. Aligners are very good for that, but look at the face. You can procline incisors, very simple to do, but be careful based on your lower incisor mandibular plane angle that you're not going to tip them in an unstable position. This is where we do most of our work, intrusion of incisors. But you can do combinations of those. But you need to relate to the lab which way you're going to do it. So extrusion of posterior teeth occurs easily in fixed, because if you put an anterior bite turbo, the molars have nothing to stop the rupturing. Harder with aligners unless you plan it, because your aligner has coverage on both your molars. So this is where you may have to stage chopping those aligners. Why I don't want 30, why I only want 10, and in aligner 9, I'm going to just destroy the posterior part of the aligner, put some buttons on, use some elastics to extrude, rescan for the next stage. Can you see how we're going with this? Right. Intrusion, where's my attachment? What attachment do I need? Greater than 1.5 mil, TADs. Do I want to intrude upper or lower? Is my intrusion going to occur by some tipping, or is it pure intrusion? If it's pure intrusion, a different type of torque. Uprighting, very easy to do, but do I need to upright and extrude, or do I need to upright and intrude? If I need to upright and intrude, I'm going to need TADs, buccal shelf. Proclination, yes, we know that that interincisal angle, which is increased, now needs to reduce, and proclining the incisors will help, but I don't want to procline my laterals in the Div 2. It's the centrals. the point I was making is, if that's an aligner case, deep bite, I'm going to use common sense mechanics, and I'm going to say, you know what, let's throw a TAD in, let's put a button on the mesial of that tooth, let's run some power chain to my TAD, and I'm going to I'm going to upright and intrude the molar. And then I'm going to start my aligner case. And I've just saved myself 6 months of aligner headache? So you can do that. Then you can scan and start your aligner movement. And ultimately, if your goal is to have a bridge or an implant, you need to allow that to remodel so that you get a good crown-root ratio, and that's where you've got to be careful. Anyone can upright and extrude, but sometimes you get to the stage where there's so much extrusion. See, an adult who has a mesially inclined molar, they've got a lot of bone loss on the mesial. People don't realize that. And then when you upright it, now all of a sudden you have almost a periodontal concern. So that's another thing that we look at. Right? Okay, so to summarize what we've covered in series 2 of our clear aligners. Now, those who are following me on YouTube, Instagram, God knows whatever else. The only thing I don't do is TikTok. Why don't we do TikTok, Adriana? Do we have to, what do I have to do on TikTok? Or do I need a TikTok crowd? I believe you've got to dance and sing. Izzy, you can look after that side of the equation, yes or no? Huh? I think TikTok is designed for people who have ADHD. Is it sort of like attention span of 1 minute? Is that right or not? Huh? Exactly. My point exactly, Teresa. But definitely for those on Instagram and YouTube and Facebook and whatever else, please come along either online or in person, which we much prefer, for our mini residency. We started our next batch. We've done only course 1. Course 2, I think, is in 4 or 5 weeks. So if you're interested, please, I think here is where you put your little contact, whatever you need to do. And we finished, they're the wrong dates, I think that's from last year, but we finished module 1. Now module 2 is really where we go through a lot of these protocols in detail. That's 2 full days plus 6 or 7 online clinical sessions where you present cases and we guide you through. But have a look at that. But to summarize what we've done, and this is my colleague, Dr. Isabel Drilling, very talented orthodontist from Spain. Spain is where all the action is when it comes to aligners, really is, right? You look at the big names in aligner therapy, Avan, Diego, they're all Spanish. And there's a huge, patient wanting aligners in that. So they've realized, well, this is what patients want. How can we achieve good results and keep the patient happy? That's why they're so successful in what they do. So protocol for our deep bite cases. Rule number 1, 1.5 to 2 millimeters of intrusion or greater, you need to supplement that intrusion with Anchorage. I like TADs. Chris Chang, the 1.5 times 8, right? Stage it, 3 important stages. Stage 1, upper arch development. Stage 2, incisor, intrusion and torque, leveling curve of speed, frog stage. Stage 3, bite jump, which could be bite ramp or the twin block type thing or whatever you want to do. Sometimes, I've done my stage 1 and 2 and then I've got a raging overjet. And I'll say, right, we're going to dump out, put a Mara in now. And post-Mara, we're going to rescan for the rest of our aligners. Now, I can do that because we're only making 10 sets of aligners per time. It's really hard for you to be able to communicate that to a lab where you've signed up for that, but you can. And that's why I say to you, don't be cheap and go for the limited aligner, because if you do proper mechanics, you always need unlimited aligners. And most of the companies now are quite good. If you sign up for unlimited, they give you 5 years to finish the case, which I factor in relapse as well, right? So when you're shopping for aligner fees with whatever company, do you get unlimited? Because you'll need it, because you're going to be rescanning a lot if you do the proper protocol. Number 2, are retainers included? Yeah. Number 3, how many years of unlimited do they allow you? If it's only 2 years, man, that's not good. If they give you 5 years, That's pretty good for those relapse cases. And every case is a relapse case, unless you put fixed retainers in, okay? Even with fixed retainers, they're not going to maintain your upper arch expansion. So a lot of these cases, I'm finishing in a Damon splint. I think we talked about that in the last course. Upper and lower vacuum retainers joined together. So I'm maintaining my arch expansion. I'm maintaining my AP and my vertical, particularly if I've had molar extrusion. That suck down retainer is so good, it locks those in. Remember last course I said, leave your IZC TADs in because you can run elastics as part of your ongoing protocol. Here, what I'm saying is you want those lower incisors to stay intruded. You want any molar extrusion that occurred not to relapse. So that's why you're going to really lock it in, all right? So the staging, I've gone through. What are resources for you from this course? The Neil Kravitz article, fantastic. There's another article that I will send you by Dr. I'll just bring it up for you. So when you send me an email, this is a classical article, Biomechanics of Deep Bite Correction, Charlie Burstone, the Burstone mechanics. And I'd like you to use those in the lower arch, maybe before you start cases, if you don't want to use TADs with aligners. Then, this article, and Mario Greco is an Italian orthodontist, again, who's been on our program, and again, his lecture. Now, Adriana, this is what we need to figure out. When he did that Zoom stuff us during lockdown, we didn't record it? But it is a lecture for him somewhere. We need to, anyway, he's done an article in the Journal of Orthodontics in 21. I'll send you this as well. Precision bite ramps and aligners, right? So if you want to understand those bite ramps, this article is just superb. So that's article number 2. I'll give you this handout, which is from TP Academy, which goes through protocol. I'm trying to give you as many resources as I can. I'm not charging for this. I just want you to learn and get better. But for those things, obviously you'll need to send an email. My suggestion would be to join Teachable and then use that platform, or email info@derekmahony.com. Now, I left 5 minutes for questions. It's 10:25. We're going to finish on the time at 10:30. We started at 9. Thank you for the people who came live. For those who are at home, thanks for nothing. Very hard for me to motivate myself, looking at a computer. I thought after COVID finished, like we'd be so over that. But now I realize, my God, it's like everyone's used to Zoom. Yeah? To me, the only thing good about COVID and Zoom, I call it the Zoom boom. My productivity doubled because everyone's at home on Zoom looking at their shitty teeth going, oh my God, now's the time I need to get ortho. And they had disposable income because they're not traveling. So I might introduce another COVID. I'll speak to my Chinese friends and see how we can get that shit going. But until that stage, please come live. There's no masks, right? All right, Terza, question.
For your sagittal correction, are you using carrier motion appliances anymore?
Yeah, so that's if I've got a sagittal that I need distalization. Carrier calls it motion, but you and I know it's a distal driver, okay? So the answer is yes, if my planning was to get a reduction. Then, those class 2 div 1s where it was a thumb sucker when they were younger, and really they have that overjet that needs to reduce, or the Chinese, I can't get my lips together even at gunpoint. Those sorts of people, yes, okay? The girl I showed you, which face is probably ruined by yeah. So the answer is yes. And in fact, one of the lectures that we definitely have on Teachable by Dr. Greco is class 2 distalization using aligners. And he talks about motion, yeah. And the good thing about motion, now they have the aesthetic version. But again, at what stage you want to start your motion? Do you understand? To me, I want to do that upper arch development anyway. So I will say, let's do the upper arch development, then let's do the carrier, and then let's continue, okay? But a lot of these cases, I find need that, and as a result, I don't really use the motion. Now, there is some controversy to say, with the motion, the class 2 elastics, am I getting some of that? Probably, but I still feel if I really look at the case, and I don't know until I've done stage 1 and 2, right? What is my overjet? If my overjet is huge, and I can see that chin point is still retrognathic, and I want to, then I'm going to use the bite jumper. A bite jumper is a totally different mechanic to the motion. So yes, do I use motion? Absolutely, but more in my 2As, not my 2Bs. Doctor, just microphone, just because the people won't hear the question.
Thanks, Derek.
It's on. Yeah.
I did miss your last lecture.
Yep.
So I just want to get my head around the bite tax. How do you intrude and extrude molars?
Yeah, so you definitely missed my last lecture. There's the answer to that question. You are what we call the great unwashed. You understand? I'm not going to waste my time answering that question. Go to course 1. Okay. I will answer it to you one-to-one, but yeah.
When you upright the 7,
Yep.
and then there is a lot of recession in the mesial.
You need to speak up.
When you upright the 7,
Yes.
there is a lot of recession in the mesial. Do
Yeah.
you send them to the perio?
Yeah. When I see there's bone loss even before, I warn them that they need to see the periodontist. I have a very good periodontist. She does a technique called PAOO. What that means is she does microperforations, and as I upright, I'm actually getting all the cells I need for bone repair. You understand? Right? Now, if I have any active periodontal, no, I'm not touching that case orthodontically. So please understand, these might be cases, like last thing you want is supragingival calculus, right, being intruded. Make sense? So I want a patient who's got good hygiene. As I've uprighted, and now I need to intrude, people don't get this, but you can get reattachment by intruding teeth. No one but an orthodontist understands that. You understand? Everyone does these flaps and guided membrane and all this sort of shit. Trust me, if you have good intrusion mechanics, you can get reattachment. But you need to make the concrete liquefied.
While we're doing the PAO, can you continue with the ortho?
You have to. PAO only works during tooth movement. You understand? You need the stimulation of the tooth movement. The best article on PAOO is by Wilco and Wilco, Seminars in Orthodontics, same journal Neil Kravitz. The first article I showed you was published in, and it describes it really well. PAOO is a technique where you need tooth movement to stimulate the repair. So what happens, it's a bit like distraction, right? In distraction, you create the injury, cells come to repair, then you do slow movement, exact same as PAOO. So if I have an adult, like she was talking about distal driving, it's very hard to distal drive a molar in a 40-year-old brachyfacial individual. But if you liquefy behind the molar and around the molar that you want to, it just whizzes along. Do you understand? In theory, not that I promise this, but let's say I have a patient, I had one the other day, that lost the 6 and the 7's like that, right? Now, the deal is the patient would ideally like to avoid an implant. So those mechanics are upright, liquefy the cortical plate, so I can then mesialize. You understand? Doing that is really good with aligners because any bodily translation, I get really good control. With ortho, I tip. So movement is like that. Yeah. But again, I'm not going to be able to do that if the bone is concrete. So in that technique, you know, if you look at that occlusally, you have a knife ridge, right? If this is, I'm just exaggerating here. You know, here's your 5, here's your 7. Now you've uprighted the 7, but that's your bone, okay? And the patient wants that. That's where it's a special technique where she will do this to the cortical plates, and then she'll microperforate. And during that, I'm moving the tooth. Okay? So it's PAOO, Seminars in Orthodontics, and it's Wilco. Beautiful article, describes it well. Good periodontists are very hard to find. Most periodontists in this country are too busy doing implants. Who would agree? They don't even do perio. Finding one who does really good soft tissue stuff, and this, American trained, perfect. Anyone trained in Boston, home of PAO, right? So luckily in Sydney, we have 3 trained people from Boston U. I have a girl that I work with who trained in NYU. They taught this routinely because the goal for them is, you know, soft tissue work and things like that. Yeah. So I can share that name with you. Yeah. But I do a lot of work. The more you have adults, which is come out of the woodwork because of aligners, the more you have thin gingival biotypes, chance of recession, and solid concrete to move teeth into. Give me kids any day. Do you understand? Yeah. Like sometimes I start conversations with adults in my case presentation. Mrs. Jones, you're clearly not the right age for treatment. Right? The more I under-promise and over-deliver, the happier the patient is. If I say, yeah, I can do this, blah, blah, no, you know, I'm painting a picture that's bleak. It's not my fault you lost your 6 when you were 7, and now you're 40 deciding to get something done about it. Do you understand? Let them take that responsibility. All good? Yeah, but if you're doing the stuff I'm showing you in a young individual, right, that had the 6 out a year ago because the root canal failed, no problems. But someone who's had a missing tooth there 3, 4, 5 years with necking, I need that PAOO. And it's very predictable movement. Will A6 angel aligner work for non-growing patients? Yeah. So with a non-growing individual, you can't stimulate mandibular growth, but you can reposition the mandible and hope for joint fossa remodeling. So the answer is yes, but not if it's a surgical case. So this is, I can't even pronounce his name, Dr. Kashir Shamidini. Doctor, I want you to read the research on joint fossa remodeling by Buck Rabi. You can see it in our course on Class 2 correction online. And I want you to measure mandibular length, which is condylean to gnathian. If mandibular length is normal in a non-growing individual, yes, I'll use an A6. If mandibular length is small, that's a surgical case. So more than likely, I would have warned in consent that I'm getting things ready for mandibular surgery at that stage of my aligners. And I have lots of cases where I use aligners to do my pre-surgical orthodontics, create the overjet, ready for surgical advancement. Next question, what elastic size do you use for the intrusion with TADs? Okay, I like using 5/16 inch, the 6 ounce. Next question, in Class 2 Division 2, do you find it hard to insert aligners due to path of insert issue? No, because I'm not really putting attachments at that stage until I correct the Div 2. Okay, in a harmony deep bite case where there might already be little room for the appliance anteriorly, is it possible to incorporate bite turbos into the custom brackets? Yes, in a deep bite Div 2, you can't put a turbo behind the upper incisors because you get incisor interference. So what you really need to do is create the torque, and you can put composite on your canines at that stage. Never put bite turbos on laterals because laterals have thin roots, and that jiggling intrusion force will give you root resorption. So you never ever put bite turbos on under-torqued teeth, on teeth with a history of trauma, on lateral incisors. Canines are a great tooth for a deep bite for turbos. What I find a lot of people do is they cheat. They got a deep bite, but it's easy to put turbos on the molars. So they disclude the deep bite on the molar, and what they're doing is they're allowing their incisors to over-extrude, deepening their bite, and they're intruding their molar, which is total idiot work, right? So what I'm saying is, if you can't put a turbo because you have either too much of an overjet or too little an overjet, then you need to torque your incisors, and as you're torquing your incisors, use your canines for that. All right. Okay, I think we've got a little bit running over time. We want to go for our break, but there is, let's say, one more question from the live audience. Yes, doctor?
When you say a large overjet.
Yeah, greater
When-
than 5 millimeters.
Oh, okay.
Yeah.
So over the 5 millimeters, you,
Yeah, it's very hard to get a bite ramp with a 5 millimeter overjet. So then as I'm reducing my overjet, if with class 2 elastics or bite jumpers or whatever, I can disclude on a canine. Make sense? Yeah. Now, the good thing with the liners is you're not going to get what's called that incisal interference as much as you get what she's talking about. Whoever asked that question was asking about the lingual braces, because lingual braces are very good for Div 2s because the actual lingual brace is your bite turbot. Okay? But if you're doing labial work and you want to get the turbos put in, then yes, you need to be aware of that. All right, so doctors online, on YouTube, on wherever, thanks for your attention. I hope you learnt some information on that. The next free CPD aligners will be on class 2, and then we have one on class 3, and then we have one on 4 bicuspid extraction aligners. So they're the 5 series. Last one was open bites, this is deep bites. We have class 2, class 3, and then extraction cases. So I hope you can join me for those series.